Hey, Cam followers. This is going to be a very, very interesting Facebook Live tonight. I am really, really pleased to introduce you to the lovely Dr. Jen Vitucci. We've been having a blast, actually, for the last half hour getting to know each other. I think we're solid friends now. It's totally cool.
Yes.
And what we're going to be talking to you about is something that is really quite new in the canine world. So I'm hoping your ears are going to prick up and be really, really like, oh, this is exciting. Because somebody had the audacity to once say to me, arthritis, Hannah, that is so boring. And I'm like, you have no idea the tools that we get to play with. So hopefully you're going to be blown away with how OA management is advancing at a rapid rate. First of all, I want to say thank you to our sponsors. So thank you, PulseVet, for getting behind us on this one. So they are leaders in the field producing extracorporeal ShockWave Therapy technology, and they are the ones that are sponsoring tonight and bringing us this lovely Dr. Jen Vitucci to come and talk to you. So thank you, PulseVet. You're absolutely fab for doing this. Right, Jen, tell us who you are.
So my name is Dr. Jen Vitucci, and I currently live in Florida, and I am the small animal business manager at PulseVet. And I was telling Hannah that I owned a practice, a couple small animal general practices with my husband for the past 12 years. And so I just left full-time clinical practice earlier this year. And I'm also a certified canine rehabilitation therapist through CRI. I started that journey in 2019 and finished through COVID in 2021. And so I'm super excited to be here. Thank you so much for having us. I'm
super excited because this modality, I think, is really, really interesting. And for me, I think there's a lot of prospect with it being incorporated into first opinion practice. And so hopefully we'll kind of like explain what it is, how it can be used, and people can then come to you guys and speak to you further about it. So we will leave some contact details. If you are a veterinary practitioner listening, a nurse, a therapist, and you want to know more, we will give you contact details so you can speak to PulseVet and get more information. So I am organized. Last year I wasn't. This year I have an agenda. So what we're going to do, first of all, is just talk about extracorporeal ShockWave therapy. We're going to call it ShockWave because otherwise it's just a mouthful. So ShockWave therapy, and then we're going to have some slides talking about the technology behind it, and then we're going to go into some further questions. So first of all, kind of just give us a really brief overview of what it is, how it's used, and then we'll jump into your slides.
Okay. So the basics of shockwave is it's a high energy sound wave that is deposited into the tissues, and this sound energy creates a biological response at our cell level. And so I always tell people that it causes the cells to release these happy, healthy healing enzymes, and it brings blood flow, and it's good for all sorts of indications in humans, horses, and as you mentioned, now in the canine. And it's good for tendon and ligament injuries, OA, back pain, chronic wounds, infected wounds. It's great for. I know we're on the arthritis management, but lick granulomas, it's amazing for, which can be an issue in our canine patients, and great for bone healing. So speeds up bone healing, non-unions. And so that's kind of just an overview. And we're going to talk a little bit more as we go.
Yeah, we're going to go into more detail. Yeah. But I can remember seeing it for the first time at a trade show probably about 5 years ago. And I was just like, what is that? That is ridiculous, because I kept hearing in this conference hall this somewhere in the distance. Yes. It was super loud. And it was by a company called Cruise. And they had a shockwave machine. I don't know which brand they were marketing. But now, because I'm interested in the rehab side of things, and I talk to a lot of rehab practitioners, it's becoming quite mainstream in rehab clinics, isn't it? Yes. A lot of people own shockwave, but it hasn't fallen into first opinion yet. So let's see where we go with this. Why don't we jump straight into your slides, let you do all the technological explanation, and then we can talk about how we use it in practice. So if you'd like to share your slides with me, I'll put them up. Okay. Here we go.
Is that good?
Perfect. You're looking good.
Okay. So as we said, ShockWave, first of all, it's kind of a scary name, right? So I don't know why we called it that to begin with, but it has nothing to do with electric shock. It is a high energy sound wave, and it's a natural phenomenon. So the best explanation I always give is it's lightning and thunder, right? So when you see lightning go off, that's the impulse. And then you hear this big boom of thunder. And sometimes it comes down and you'll feel your windows shake or your sides of your house will shake. And that's actually a shock wave. And that energy hits your house and it gets deposited and causes your house to shake. But obviously, when we're talking about medicine, we want to focus and direct that shock wave, right? We don't just want to, lightning and thunder everywhere. Mm. And so the simplest way to explain it is that when the energy gets deposited into the tissue, it hits an area of impedance, right? So it's going to hit a bone, tendon, it's going to hit the cell surface, similar to the walls of your house, and it causes a sudden pressure change. And the cells react to that physical pressure change, and it causes them to release, like I said, these growth factors and cytokines. And the basic overview is what they do is they increase blood supply, they decrease inflammation, they increase cellular bone production, and they improve fiber alignment and tendon repair. So they cause all of these things to happen in the tissue. And so we want to be very specific about where it goes and how we're making those shock waves. So this is just kind of a fancy slide. We know exactly what's released, right? And what it causes. So BMP, TGF, just all these kind of fancy names, right? Causing a bunch of amazing things to happen within the tissue.
Just explain to the followers what those abbreviations are. So they're like, what's TGF? What kind of things, really simply?
Oh, yeah. So tissue growth factor. So that creates tissue healing. It basically increases cells and causes them to do great things in the tissue. And then these top three, the NO is nitric oxide, VEGF, PCNA. Those are big, fancy names. They all bring blood supply. So anytime
you need blood supply for healing.
Correct. So anytime you want healing, you need to increase blood supply. It's also going to decrease waste, right? When you bring blood, you're going to bring healthy things, and that blood's going to be able to take things away and increase your lymphatic drainage as well. And then BMP is the one that stimulates bone production. So it actually stimulates that enzyme to cause bone cells to grow.
Cool. Good job.
Okay. And I'm not going to go over this a whole bunch, but there's a lot of modalities out there, and we're going to talk about this more, but it's just kind of explaining that they all serve a purpose, but they all do different things, and they all have different protocols. And so I think one of the most important things to me that I always look at, which we're going to talk about, is, we have a lot of research behind shockwave. It doesn't require a lot of treatments. It's 1 to 3 treatments total for longer term healing. And so that's really nice.
And I think that's really important, so CAM is quite a nightmare to run because we really try and stick to evidence. Mm-hmm. So for people that are listening, it could be really easy to fall into anecdotal stories. Oh, well, that sounds really interesting. That worked really well with that person. Oh, let's talk about it. But where you could go with that is just above and beyond, because there's so many anecdotal interventions for osteoarthritis. So what we try to do is make sure that we talk about things that have been clinically researched, so that we've got some kind of defining line of what we're comfortable to advocate and talk about. And it's really difficult, guys, don't get me wrong, because the vet sector has a lot less evidence to refer to than, say, the human sector. So we're always going to be short on evidence. But what we try and do is navigate what is available and what information is there to really support it. And we're not talking about just case studies. We're talking about controlled clinical trials. And one of the reasons that I'm happy for us to be sponsored by PulseVet, which is something that we don't do very often, I hope everybody notices, is that there is data to support this. So we're not just doing this on a whim. It's not just, hey, Cam's just talking about something, getting a bit of money in their back pocket with a sponsored Facebook Live. It's not about that. It's actually, this has got some clinical evidence I feel comfortable demonstrating and introducing you guys to it. So I just wanted to make that really clear.
Yes. And as we were talking about, and part of the reason to me that PulseVet was such an attractive place to become a part of is they really believe in the same thing. They really believe in doing the research. And research is so difficult, right? Doing controlled prospective studies is super hard, super expensive. And once you start, you really have to know that you may not get the result you want or you thought you were going to get, and it's still going to be out there forever. And so I think that's a huge thing to me. Like, if you start a study, you better be prepared for what the answers are going to be. And we've done a lot of studies and we've always had positive results, and that's huge. And
that's really true. And when we talk about studies, I happen to know of a very cool bed company. And I happen to know that they did a pilot study into the benefits of the orthopedic bed. And I happen to know what the bill was as well. And we're talking tens of thousands of dollars. We're not talking about a quick whiz of 3-week trial. Yeah. This went on for months at great expense. And as you said, the owner of that bed company was investing not knowing whether they're going to get a positive result. So this is like gambling marketing on a big scale.
And if you get a negative result and you publish it or it's known, it's out there forever, right? Yeah. You can't fake the science. You can't take it back. Whereas anecdotally in case studies, you can kind of spin those a little bit and pick out the best ones that worked well and not take the good with the bad. So
good. Right, can continue.
Yeah. And that is why, I don't know about in the UK, but in the United States, it is covered by most canine insurance companies. And we talk about that not because a ton of people have insurance, but because to me, it means it works, right? Or they believe it's going to work, because why else would they cover it if they're not covering other things that don't have the same level of research and results that we have?
Yeah.
And the treatments, as I said, they're quick, they're easy, and they take less than 5 minutes. And so it's just an awesome modality to start talking about. And so this is our little canine skeleton over here. And just talking about all the things, it can treat. We're going to focus today clearly on osteoarthritis. And I also put chronic pain because we're doing a big study, which I'm going to talk about, on back pain, which I include in the, spondylosis, in the arthritis management. But you can use it in all of these places for OA, for tendons, ligaments, in the dog. So it has a lot of uses. And we're going to talk about this research. So I'm not going to go into this slide that much, but that is a very, very cool fracture right here that we treated with ShockWave.
Wow.
I know. Look at that healing. It's amazing. But I'm going to go into more detail about all of these other ones.
Okay, cool.
So, and the biggest thing always for, all veterinarians, especially in small animal and for all of our owners, is, okay, we're talking about this. What does that mean? What's going to happen to my pet, right? So we figure out where we need to go, where is painful. We do need to shave. So this is since it's sound energy, it's similar to ultrasound, right? We need to get good contact with the skin. So we need to shave the area. And we use ultrasound gel to make sure that we have really good contact and no sound waves go in. And we kind of move the trode around. I know we talk about laser a lot. So I would say, I always think of it similar to laser, where we want to move the trode. And the main reason for that is we want to recruit the most cells that we can to release these enzymes, right? To increase the tissue healing. It takes about 500 to 1,000 pulses per treatment area, 1 to 3 treatments, 2 to 3 weeks apart. And it's about 3 to 5 minutes for a site. And afterwards, there's usually one of two things that happen. They either feel great. We get an analgesic effect for a few days. And this is important. I always mention to owners, because how we all are, I have a dog, his name's Vocal, and he wakes up and he's been painful and all of a sudden he feels great. So I want to do all of these things with him, right? Like we're going on walks, we're hiking, you know, and don't do that because we still have all of our underlying issues and we're going to cause more problems. But you know what I'm saying? Then you call me a week and say, oh my gosh, my dog can't walk now. Well, you know, we still got to do it.
Luna has just decided to find the only squeaky toy in the building. Luna, come on, give it here now. Come on. Seriously? How does that happen? Yeah. Come on, give it.
That's the joy of the life, you know?
Please continue.
The other option is because we're increasing blood flow, and a lot of these are chronic injuries, and we're making them acute, right? We're trying to restart the healing process. We can be a little uncomfortable, and nothing that a non-steroidal or another pain medication won't take care of. Okay.
Yeah.
But
just pause there and tell people about the bringing something from a chronic state into an acute state in a really simplistic terms, so people can kind of go, what? Because I'm sure that a lot of people go, wait, you're just going to make it worse. No. Explain how turning something from a chronic state to acute state is actually in our favor in situations like this.
So once something has reached the chronic state, our body is used to it and they're ignoring it at this point. And I always tell people it's not the same as a scar, but I kind of think of it in my mind as a scar, right? We've sort of put a patch down over the problem and it's not back to normal, but it's a little bit better. And so what we want to do, and like you're saying, we're not making it worse. What we want to do is tell the body, no, this is a problem. We need to heal it. We need to bring in more blood supply, bring back these cells. And that is why occasionally it can be just a little bit uncomfortable for the first couple of days because, you know, we're causing the body to notice this problem again. And we want that because otherwise it's going to be in that static state forever until we give it the boost that it needs.
And I've had limited use of it, but when I have used it, I would say in favor of the analgesic effect I've seen in that more dogs came out feeling better very quickly than the dogs that were sore and needed a little bit of a top-up pain relief for the interim.
Correct. That's been my experience. I would say probably 60 to 70 to 30, 40.
100% like that. Yeah. Agree.
You know, that have had any real problem afterwards, or it's been more uncomfortable.
Yeah. Have you actually done it on yourself?
Oh, yes.
So have I. I did it on my toe.
I've done it on myself. I've done it on my husband. I do it in every clinic I go to because, you know, I think honestly, the best way for people to see it is to feel it themselves. Yeah. And I'm not going to do anything on your pet that I wouldn't do on myself. Right.
Well, no, I totally agree. And it's that slight intrepidation, isn't it? You kind of opening the box, you're getting the trode out and you're like, and then you're like, actually, the initial, it's a bit like, whoa. Mm-hmm. But then you very quickly seem to get that analgesic effect for the first, say, 20 to 30 shocks. You're like, oh, God, bloody hell. And then you're like, actually, this is all right. It's a bit like cold water getting in the sea. And then you just kind of go, I can deal with this. But,
and then it kind of settles in. And I will say, okay, I'm done with that. So do you want me to stop?
Yeah.
Okay.
So do you want me to put, I can put you perfect.
There we go. And the biggest thing that we are hoping and we know is going to make it even more accessible now in our canine patients is we have a new trode that launched this year. So our traditional trodes can be uncomfortable, right? So that ShockWave, I'm going to actually show you the trode if this is an okay time. So we have an electrohydraulic, and I know this is on your agenda, right? But the point is that it has a very large focal area and a high peak energy. And so sometimes those little pops, they can be a little uncomfortable. And so what we've done with the new trode is we've designed a new reflector that lowers that peak energy and it makes it much more comfortable. And so in the past, patients have been needed to be like pretty sedated, right? Yeah. Because we don't want them to be in pain. And that's a huge barrier, especially the time, money for the client, the risk of sedation in these patients, and then you have to have a technician and monitoring, right? It's now a whole thing. Whereas if you can do this awake in 5 minutes, it's like, oh, no brainer, you know?
Yeah. Well, this is a perfect point to actually just talk about the different kinds of shockwave, and we'll kind of we'll try and just do it in a very non-biased way of these are the different types and these are the potential benefits, because up until recently the electrohydraulic has been a little bit of a bit more difficult to use because of that sedation requirement. But if you can just explain the 3 different types, and then also we can talk about focal and diffuse radial.
Yeah, because radial is the 4th one, right? There's 3 other ones, and then radial is like the unfocused kind of diffuse energy.
And you can use your hands if you like.
Yeah. This way. Electrohydraulic is just what it sounds like. So electric in water. So this is technically a spark plug in water. And so we create an impulse inside here. This is a fluid, little squishy membrane. And then we focused the shockwave energy with our reflector out through the end. And there's actually a double wave, right? Because you're going to get some that go straight out, and then you're going to get ones from the reflector as well. So you're going to get this double sort of wave of energy that comes at you.
And guys, if this was the tissue, that means it's kind of doing that way. It's coming down and focusing.
Yes. And the other types, and I don't know in the UK if this is common. It's not super common in the United States. There's an electromagnetic, which uses electric and magnets, like a loudspeaker, right? Your loudspeaker booms. And similar, it's going to go like this. And the third one, which is super important because it is more common, especially in small animal in the United States, it is a piezoelectric. And what it uses, similar cone shape to focus it, is these vibrating crystals to create the sound energy. And the biggest difference between those 3, and the only reason, not the only reason, one of the main reasons it's so important is because they have different focal volumes, right? So different, as we're going into the tissue, how much tissue are we affecting, and different peak energies. And so the other 2 have never required sedation because the peak energy's been lower and they have a very small focal area. And so it's sort of like a laser pointer and a flashlight.
Yeah.
And that's important because it just changes our treatment protocols. Okay. So to deliver the same amount of energy between the 3, it requires different time lengths and different treatment frequencies. So that's to your point, the very unbiased difference is that a piezoelectric, to get the same volume of tissue hit, you're just going to have to use it more, right? You're going to have to go around. It's going to take a little bit longer, and you're going to have to come back more frequently. Whereas with a larger focal volume and greater energy deposited, you're going to affect those cells quicker and with less frequency. You know, you come back in a couple of weeks, every 2 to 3 weeks. Whereas the piezoelectric and the electromagnetic, piezoelectric's a couple times a week as opposed to 2 to 3 weeks. And electromagnetic's kind of in the middle, right? It's
and then where does radial fit in here? Because radial, people that have had horses have probably experienced radial shockwave a decade ago. You know, it's been around in the horses for a long time.
And they're still out there, right? And the biggest thing with radial is it's not focused energy. So we don't really have a great handle on what is being affected when we treat. We don't know what
tissue this way. So it's coming out and it's dispersing over a wider area rather than that way where it's coming down and targeting.
Where it's coming down to a point. Exactly. And so radial, we don't know what cells are getting what energy, because it just sort of, as you're describing, it just scatters as it goes down, as opposed to the opposite, where we're really trying to like bring it to a point and treat a very specific area with focused shockwave.
So there's a number of variations of shockwave, and just understanding that's quite important. So if you were to see a rehab center and you've listened to us and you're thinking, well, they've said it's like once every 2 to 3 weeks, and the rehab center says, you're going to have to come in twice a week. That's the difference. They've got a different machine. Not bad, not good, just different. And we don't want you to get confused.
Yeah, that is confusing. I think when people come in, they're used to one or the other, whether they've been in a couple times a week, and now we're saying 2 to 3 weeks, or the opposite. To your point, it's still shockwave. We're just delivering it differently in different ways.
So now let's move on to the evidence behind this, because as I said, I really don't want to tripwire ourselves. Cam's done very well for many years trying to keep really close to evidence and being as honest as we can do. So one of the reasons I feel comfortable with this is because we do have clinical evidence. So can we talk through, should we start with OA, and then we can kind of like verge into tendinopathies and unhealing wounds, etc.
Yeah. And so I'm going to talk about one of the big studies at University of Tennessee, and it wasn't huge. It was 15 dogs, and they had end-stage elbow disease. Okay. So these are like, it's kind of your last resort. We've been treating them with medical management and medication, and they're not doing better. And so we looked at those dogs 0, 14, and 28 days, and they were shockwaved at 0 and 14 days. And we measured, and I say the doctor, I wasn't there, Dr. Millis at Tennessee and Dr. Drum. And we measured ground reactive forces, right? So we really tried to pick like a very objective measure. Are these dogs doing better? And their ground reactive forces, their peak vertical force, peak propulsion, which those are big fancy terms, right? When we have the dog walk over a plate and we're measuring how much pressure they're putting on each leg, okay? And those dogs that were treated with shockwave increased 4.5% to 5%, the mean did, on these ground reaction forces, which doesn't sound like a ton when you say that, but that's similar to what the non-steroidals would do in this same thing. And this was 2 treatments of shockwave 14 days apart with, no medication, no possible side effects like that. And they actually went through afterwards, and the dogs that were in the control group, they allowed them to be treated with shockwave as well, and they had the same results. So, yeah.
So let's just pause and let's just talk about ground reaction forces a bit, and just kind of, so if you've got something painful, you will want to put less weight on it. You'll be trying to offload it when walking. So your ground reaction forces will be less, and they measure on this this kind of treadmill situation, this force plate. So if you're reducing the discomfort, then there's going to be more faith in using the limb. So then you're going to put more weight on it. So there's going to be more force going through it. So it's a very, very objective way. And it's one of our most objective ways of measuring if we see improvement. Now, it's obviously we've got behavior change and stuff. And that's where these questionnaires, which we've talked about before, guys, come in brilliantly. But this is a well-respected, objective measuring manner.
Yeah.
So yes, which is great. So that's cool. What other things have you got up your sleeve that you're kind of pretty proud of shouting about?
So I think one of the most exciting ones there's a pilot study that they did in California at a surgery center where it was retrospective of 40 patients, mostly dogs, a couple cats, and they were treating back pain, so non-neurologic back pain. Okay, so I just want to be, as we're talking about, we're not talking about disc disease, we're talking about arthritis in the spine, or, kind of narrowing of the canal at the lower end of our back, right? And they went back through, and these patients had received, most of them only got 1 shockwave treatment, and they had an 87.5% positive outcome. And this was, to your point, it was subjective, right? So we had pain scores and lameness scores by the doctors. And then we did questionnaires to the owners, right? Like, are we changing behaviors? Are we improving? And then we did a short term and they did a long term follow up. And they found that they spoke to a lot of these owners. The median time was 13 months later. And the owners, again, another 87% of them reported that the pets were still improved. A couple of the dogs had 2 treatments. And so that was super encouraging, right? Because lower back pain is such a huge, whether you start there with arthritis or it's a big compensatory, right? And as we're talking about with clients, when our hips hurt, we have to utilize other parts of our body to get our gait. And so our back starts hurting because we're kind of, I call it the waddle, right? Like they have to kind of swing their hips around. And so the encouraging results of that, there is now a very large study going on at Ohio State with Dr. Kivas where they are treating dogs 2 and 3 times. We're getting close to wrapping that up. And to your point, it's a prospective blinded study and they're having super exciting results with it. So, and I don't have, we haven't statistically analyzed it, but everyone's really excited about that. And I think that would just be huge. I feel like every older dog has lower back pain. I don't know. Just like people, right? Like we all have lower back pain.
No, definitely. And I think that's something that people, I think both the veterinary profession, the canine professionals and the owners really have to understand that it isn't all about the joints. And I still do use a diagram where I've got this dog and I'm like, well, yeah, it's hip OA and maybe we've got 40% of his current pain state there. And there's probably about 20 here and there's about another 10 over there. And he's actually shifted weight in his shoulders, probably 20 over there too. So when you're trying to improve your dog's quality of life, that's the key. That's what we want to do. We want to reduce their pain state to improve their quality of life and their independent mobility. That's the goal. So by actually treating these other areas and reducing it down, is really, really important. And having modalities that can tackle different areas, I think is really quite important. And that just also really underpins why lifestyle change, exercise adaptation, home modifications have such a big role, because you're looking after the whole body, because the whole body is looking after the hips, So I think that's really quite important. So let's just briefly talk about evidence again. A retrospective study means that we've got less control of the variables, and we're trying to pull out data. Or could that, maybe that's a coincidence. Or no, maybe that's actually causal. Yeah. But when you do a prospective study, you control those variables and you really, really nail down what you are testing. So prospective studies are more powerful, and the higher the number in the study, the more powerful it is as well. And the problem we have in the vet world is 15 to 50 dogs in a study is quite a good study in the vet sector, whereas in the human sector, it's 1,500 to 5,000 is a good study. And that's a really, really big difference between human medicine and vet medicine. So our data that we have to refer to isn't fantastic, but, these are key points. Is it prospective? Is it blinded? Are we using validated instruments to actually measure change? Are we stepping away from subjective opinion? These are all very important points. Cool. Okay. So have you got any other studies that we can talk about that have OA connection?
Those are the 2 biggest dog ones. I will say, just as a mention, and I know that rats are not dogs. I get that. However, there is a ton of really interesting prospective blinded studies, because we can do things in rats that we can't do in dogs and cats, right? Or people. And they get really down to the cellular level of OA, and they can create OA in the joints, right? And do shockwave on them. And they just had really exciting results where they can, in a rat, which is not the same as a dog, but they've been able to actually prevent some changes of OA. And we've never been, I shouldn't say that. We haven't been able to show that yet in a dog because it's difficult to do, sampling and histology and all of the things that you need. But on a cellular level, they're showing that it's increasing, the healthy osteoarthritis, preventing enzymes and decreasing the bad ones. And, we want to start extrapolating from that into bigger OA studies and saying like, okay, can we start, slowing the progression? I'm not going to say prevent because that's
no. But this is very similar to, so Mike Farrell, who is incredible. By Mike, you can actually get me a beer for that. Mike Farrell did a live 2 weeks ago.
I watched it. Yes, about the elbows.
Don't tell him that because it will go to his head, but he is amazing. And he was talking about how difficult it is to do surgical studies, especially long-term ones, to get a lifetime study.
Yeah.
Wow. But do you know what? That's like 12 years in the making. Yeah. That is expensive. But what would be beautiful is to have a cohort of dogs of a similar age, of a similar breed, of a similar body shape, with a similar problem, and divide them into 2 groups and use an intervention, a modality like this in one group and cross compare to the other group and see what happens throughout their life. Do we have development of OA a lot sooner in the control group? Wow, that would be an incredible study. But we're talking thousands, hundreds of thousands to do that. And actually trying to find that group of dogs is going to be pretty nigh on impossible. But you're talking about preventive, leads me into Tplo. So you've got a study about Tplo, haven't you?
Yes, we have quite a few studies on Tplos. And, to your point about research, a Tplo is a very easy group of dogs that we can compare things to. And so it started with, when we were talking about ligaments, it started with the patellar desmitis study that
just tell them what desmitis is, because it sounds like some kind of Italian dish.
So the patellar ligament, right, is what goes across our kneecap and holds our kneecap down, right? And so after Tplos, it's very common that ligament gets upset and inflamed. And so we knew like, hey, here's a good population to do because we know this is a common problem. And so again, prospective, randomized, blinded, we treated half the dogs, I think it's 12 or 13, with ShockWave right after surgery and 2 weeks after, usually when we take the sutures out, and then did not treat the other group. And we take normally 8-week radiographs, and we measured the thickness of that patellar ligament. And it was significantly decreased in the ShockWave treated dogs. And so it's having an effect on decreasing that inflammation and keeping it thinner and keeping that ligament healthier.
And what about the clinical signs with the dogs? Because that's what owners care about. Owners want to get their dog back. That was actually going to be our hashtag. Get your dog back.
And so that's going to decrease pain, right? It's going to decrease pain, decrease swelling. And I always think about in the rehab world and for clients, you want your dog to get back to normal as fast as you can, right? And so the other study that came out not too long ago was shockwaving was shown to improve the short-term limb use after Tplo. And so the 2 studies before then, I talked about the ligament one. There's also a bone healing one that showed bones healed faster after Tplo when they were treated with ShockWave versus the non-treated bones. Again, prospective blinded study. And what they did in this one is instead of focusing on the ligament or focusing on the bone, they focused on the whole knee joint after surgery. And they measured again on the force plate that you were just explaining, those ground reactive forces. And they were saying, are they using this limb that was treated with 2 things of ShockWave more after surgery than they were in the untreated dogs, if that makes sense?
Yeah.
So, they're walking the dogs. And as you're saying, when I'm sore, I'm putting less weight on it. And so in the ShockWave treated dogs, all of those ground reactive forces were better and better than before surgery, actually. I mean, obviously they were lame before they went into surgery, so take that into account. And the point of that being, like you're saying, what is the importance to the dog owner? Okay, well, now I'm walking better, so I'm not putting weight on my 3 other limbs. we all know that once you blow one cruciate, it's very likely that you're going to blow the other one. So we're keeping weight off that other leg, and we're preventing those compensatory problems, right? Like I always tell people, when you sprain your ankle, like your other hip starts hurting, right? Because you're like walking funny.
Yeah.
And then you can also start all your rehab programs earlier.
Yeah.
And that's huge because we're not going to lose as much muscle mass. We're going to keep that joint lubricated, just all of those cascade of positive effects that come from, getting back to work earlier. And so that's what the study showed, that like,
I'm just going to do a quick disclaimer, because just in case anybody's just cherry picking, ShockWave is not replacement for surgery. Just so everybody knows that, because I can imagine somebody just going, "Oh, I'm cooking dinner. I heard ShockWave and cruciate. Great. I'm going to go to my vet and say, hey, my dog, it's cruciate. Can we do ShockWave?" It's not the same, guys. So please listen to our Facebook Lives about cruciate if you want to know more about that. This is an adjunct to aid healing, to expedite the process. Get your dog back quicker. So that's cool. So what else? Let's talk about tendinopathy. It's got a lovely lady here saying, please, where is it? Not that one, this one. Please, can we talk about biceps tendinopathy? Let's have a quick chat about that. And then we'll talk about, there's somebody wanting to know, is there anything about gracilis? And then we're going to talk about the factual things of how much is it likely to cost?
Yes.
How are we going to get access to it, etc. So tell us about tendinopathies.
Okay. And so we have two really good studies. I am going to say they're retrospective, but they had, so shoulder lameness in any dog is a difficult thing to treat, right? The shoulder is, we can do injections, we can do surgery. It's just hard to get to. And the two studies that we did they had biceps tendinopathies, supraspinatus tendinopathies. A couple dogs had medial shoulder instability. And so these are all big fancy words for this tendons that basically go right in the front here that like control your dog doing this.
Yeah.
And
I'm going to just pause quickly. So guys, lots of people think that if there's pain in the shoulder, it's got shoulder arthritis. Actually, the shoulder is a really classic joint for having a lot of soft tissue involved in its function and its stability. And the pain might not be to do with arthritis in the shoulder. The actual joint might be as clean as a whistle, but it's the soft tissues that are generating the discomfort. So it could be tendon related pain. It could be the joint capsule on the inside has become lax, so there's instability there. So there's other things that it can be. And that's one of the biggest things about shoulders is what is causing the problem. So if you've got a dog that's got pain located to the shoulder, assuming it's arthritis is a bit of a wild guess, really. Doing x-rays and ideally doing ultrasounds and getting to what is underlying it is really quite important. But a lot of people just kind of go, oh, it's shoulder, must be OA. So I just wanted to clarify that. Shoulder pain doesn't mean it's OA pain. There's other things that could be going wrong.
Yes. And it is, as just to your mention, it's often hard to figure out exactly what's going on in the shoulder. I think just forelimbs in general really require some additional diagnostics, a good x-ray, a good ultrasound, a CT, something to really get into those tendon and ligaments. Because like you said, it's not a simple, oh, it has OA in its elbow. Like hips, we always think OA, right? The most common problem. And so I always talk about this study because it was done at Tufts with, it's Dr. Becker and Dr. Kowaleski. And Dr. Kowaleski taught me at Ohio State, and he's one of my favorite people. And so I have to talk about that. And the retrospective study was these dogs, again, it's kind of like the end stage elbow. Sometimes our ShockWave retrospective studies end up as like these were these last resorts, right? Like they weren't responding to conservative management. And I say that because they're difficult cases. It's not on the front end, right? We're on the back end. And so these dogs, the average amount of time they were laying was 9 months at this point. And so they were treated 3 times, 3 weeks apart with ShockWaves. And the short-term follow-up, it was 9 dogs that they saw 3 to 4 weeks after. 6 of them were improved and 3 of them were resolved. And then
resolved.
And the long-term phone follow-up. And again, long-term, I'm talking anywhere from a year to 2 years, right? 7 of the 11 owners that they were able to speak to and talk about the dog, the owners still considered improved. And they had not had an additional shockwave. I'm sure that they were on other medication, you know what I mean? Other things. But that was huge to me. And I, being on that's the research. And then there's another retrospective study that had similar results, right? Biceps and supraspinatus tendinopathies. And they did similar short-term and long-term.
Did any of them deteriorate?
Yes. Three of the dogs were worse. And the 2 most common, they had medial shoulder instability. And so those did not respond as well to the shockwave treatment as the biceps and supraspinatus tendinopathies did. And
so that really points that a diagnosis is pretty critical. But that's the same with any form of joint related pain, trying to get to the bottom of what's causing it. If you've got stifle pain, is it the cruciate? Have we got meniscal damage? It doesn't matter what, if it's the back, is it actually lumbosacral, where we've got nerve impingement? Taking that next step to try and find out what is the actual underlying is really, really important when we're trying to choose the best intervention, with the best evidence of, well, we know if they've got medial shoulder instability, actually, we might best be doing something else. Is that kind of like a bit of a take home from that study?
Yes, I agree. I think we know what it works well for. And if, you can always try it on anything and have good results. But to your point, it really helps the owners and the veterinarian to pick the best treatment if we know exactly what's going on. And if we don't, we try a lot of things, right? Because we want to make our patients feel better, but we can't go to a study and say, well, 70% did this or 80% did this, because I'm not exactly sure I don't have a perfect answer of what's going on in the shoulder. And
I think a really good helpful tip to a lot of owners is, there's a lot of studies out there that will say 75% improved. You're like, there was only 4 dogs, great. So just look at the numbers in the study. Yes, it's always going to be small in the vet sector compared to the human sector. But I see that a lot promoting products, and you actually try and get information about how many animals were in the study and what kind of study it was and whether it was controlled, blah, 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 blah. So just do bear that in mind, guys. Just because of time, let's just quickly jump into what is it not suitable for? So we've talked about medial shoulder instability is not if the dog's got the fact that it's, so medial shoulder instability means that the joint isn't stable on the inside margin. So it's liable to abduct more. So instead of just being able to be comfortable in what's called a sagittal plane, it's able to swing out this instability. Is there other things that it's not good for? Would you stay away?
For the most part, the nice part is it's not a tool that can do a lot of damage. So that's what I tell people. We used to even say, kind of avoid the heart and lungs. We just finished a study where we shockwave lungs and nothing happened. They're doing a study in humans on shockwaving hearts, and in horses, they're actually doing a study on treating bleeders, which I don't know the best way to explain that in my small animal mind. But it's
when they after running bleeding.
Yes.
So exertional something or other, isn't it?
Yeah, my equine cohorts at PulseVet are twitching right now that I'm not explaining that correctly.
She's fine. Let's just move on.
Exactly. I don't know why I brought it up. That was silly.
Oh no, don't worry about it.
No. So we say cancer, anything, and that's why I think radiographs of the back are really important. I'm just going to point this out to you because, for owners, you can get infections in your spine, right? Discospondylitis in your vertebrae, and you can get cancer in your bones. And you don't want to increase blood supply to a tumor. Correct. So that's an important note.
And if you've got bone that is really, really unhappy and clinging on for dear life structurally because it's moth-eaten because of, say, cancer or infection, slamming that with a sound wave isn't going to end very well.
Correct. And I don't think it would break bones. You know what I mean? It doesn't have that kind of energy, but tumors they have a lot of blood flow to begin with, right? And so if we're recruiting more cells to that area, we don't want to do that.
No.
We are always saying to be careful. We don't have any studies or any evidence that it doesn't go well, but over a known disc, right? Like if you know that we have an impinged disc in our spine, we don't want to travel right over that. I'm okay doing it near it, especially if we are sore in other parts of our back, but we just really don't want to get close to that.
Perfect.
Acute area, right?
Okay, so let's talk about fees. Now, I'm a little bit out of date, and it's very, very, very practice independent.
Yes.
When I've used it before, there's also been the diagnostics to actually get an answer of what are we treating so we can best treat it and target. So there is that expense to consider as well. So that's more than likely going to be clinical exam leading to bloods, urine, plus sedation or general anesthetic and imaging, which could be X-ray, CT, ultrasound. So you've got that prior to using it appropriately. I'm not sure everybody makes sure that they get a diagnosis. I'm sure there are people that are doing it without, but that is gold standard.
Yeah.
And then when choosing to use that treatment, there used to be the sedation. So admit to hospital, sedate, treat, wake up. And where I was working, it was around about 150 quid, say, for the treatment plus the sedation fees. So it was probably 250, 300. And then, as I say, they would either come back 2 to 3 weeks later and have a repeat. And we were looking at doing that 3 times. So you're looking at like £1,000 package. But that's really rough, guys. Yeah. That's really, really rough. Now that we've got more modalities that don't need sedation, that's going to reduce some of the cost. But I just wanted to butt in and say, as a first opinion practitioner, one of the things that interests me a lot about this is it's very common that we have a dog in that we're going to work up the lameness. And we sedate them, we put them on the x-ray table, we take the x-rays and we wake them up. And then we talk to the owner about, well, these are the things that we could try doing. And what I really like about this is, as you can see, it's very mobile. It's sort of thing that you just get out the cupboard whilst they're still on the x-ray table. You administer their first treatment under that first sedation. And I think that, to me, is a really, really big selling point of why this could become a really good tool for first opinion practice. And that I'm saying could because we still need to get a lot more data. But when you're looking at the bigger picture, I just think that that's worth its weight in gold, really. Over in America, what kind of fees would you be looking at?
So in the United States, like you said, it's very variable, right? But it is about, I don't know what conversion is right now.
Yeah.
But most people charge around 250-ish, 300 for a treatment.
Right.
And that's just the treatment alone, right? Like, so not sedation or x-rays or anything else, just for that specific.
Yeah. And I think people need to kind of know the price of the machine. I don't know how we can get away with this, but doing a ballpark figure. This isn't a cheap piece of kit. No. This isn't the sort of thing that I will just go and buy tomorrow. No. I remember it being like 25 to 30 grand investment. Is that right?
Yes.
Yes. So this isn't something that you can just go to your vet practice and go, well, why didn't you have one?
Yeah.
This is a solid piece of kit that is a big investment for a practice. So they're not going to jump into it without doing research and having a read around. So please don't go to your practice and go, well, I heard it on Cam and I think you should get one. No. There's going to be a lot of practice chit chat about whether they can actually cover their costs at the end of the day. So, okay, so that's cool. What else have I got? We've got 2 more things to cover. Where it fits within the multimodal, because both me and you were talking about this before, in that we need to step away from unimodal therapy. We need to stop just kind of putting a dog on an anti-inflammatory and just letting them sit there for the next 6 months to 6 years on the same anti-inflammatory and doing nothing else. No weight loss, no lifestyle changes, no exercise changes, no house modifications, no joint supplement. Where does it kind of fit? Is it the Holy Grail, or?
That'd be nice. I wish I could say that. I think it has instances, by the way, where it can be pretty miraculous. I've had just a couple patients that I've been like, oh, all right, I'm pretty impressed. But especially with OA, when you're talking about something so complicated, and as you mentioned earlier, we're talking about all these other things that are affected. Right now, we have muscle pain and our joint capsule, and now we're swollen and our back hurts, and it has to be part. It cannot be the only thing that you do. It just has to be part of everything else. I would love for dogs to be able to be on less medication after the shockwave, right? Just because that can have more side effects, and we know liver and kidneys and GI, we can have tummy upset. So that would be wonderful. But if you're not, I always think of it like people. If you're not worried about nutrition, if you're not worried about weight, if you're not doing exercises, if you do this and then your patient goes and your overweight patient, your overweight lovely dog sits in the corner for 3 weeks till you come back, it's not going to have the full effect, right? It's going to do well, and it's going to do everything it can possibly do to help your dog feel better. But we have to do the rest,
Yeah. Totally. And that's what CAM is all about. So, I just want people to go away knowing that they can do so much for their dog. And there's going to be many people out there saying, well, I'll never be able to access this modality. I'd never be able to afford it. Don't worry. There are still a lot of things that you can do. What's really amazing about OA is there's so many ways that we can interfere with this disease. We can intervene. And this is why, I said right at the beginning, someone once said to me, arthritis is so boring. And I'm like, seriously, there is so much that we can do. It's far from boring.
Yeah.
So that leads me very nicely in our last 3.5 minutes together, trying to do like 10 top tips. Now I'll start at 10, you do 9, I'll do 8, you do 7. And I have to use my fingers so that on the table.
Oh my goodness. I got to come up with 5. Okay.
They got to come up with 5. And they basically are, sounds so cheesy, a little bit from the heart. You've been a practitioner for a while, you've been a first opinion vet. You see a lot of people with OA dogs. What sort of things would you advise? So I'm going to start with number 10, which is my all-time favorite. More rugs, less drugs. So guys, traction. The myriad of effects that happens to the body with OA means that they are vulnerable and they cannot cope so well. So putting them on a surface where they slip, or slide, or can't get traction when they're trying to get up from a lay, it's going to put more stress on the rest of the body. And that's where there's lots and lots of other sources of pain. So please put your rugs down. Think about carpets. Think about rubber back mats. Get traction. Number 9.
I would say walking. Just take your dog, move your dog. I tell people all the time in my own practice that, okay, and I'm guilty of this too, right? We're busy. If you walk your dog in the morning and then it sleeps for 8 hours all day, and then we walk it 10 hours later, like I always tell people, we're working from home now. We're home more. Every hour or two, like make your dog get up and go to the kitchen and get a snack. It's so simple. Do you know what I mean? Like get him up and get him an ice cube, and then he can go lay back down. But they just have such a difficult time rising, right? And so just forcing them to do that. I think that that's such a little tiny tip that people are like, oh, I never thought about that. If you sat in front of your desk for 8 hours and then stood up, you're like,
I'm 43 now, and I'm like, God, I feel like a cripple when I've been sat at the desk for a few hours. It's unbelievable. So I'm going to add to that. I'm going to take your number 9. I'm going to add number 8. Think about how you feed them, guys. It's one of the happiest moments of their day is feeding time. How can you get them up and moving during that period of time? Scatter feed, put them into interactive feeders, hide and seek the food. Use that to get them moving, because motion is lotion, as Carrie Smith says. It is really beneficial. I know that if I've been sat for a period of time, first few steps, like, and then it eases off. So make use of your everyday daily activities. Number 7 for you.
And I think playing on that, do it early. Don't wait till we're 12. Make it a habit from when we're a puppy forever to include so much activity. Don't let it decline because they're getting older and you're getting older.
I like that one.
Pick a routine and stick to it.
That's good. Okay, so my number 6 is have confidence in what you think you're seeing and talk to the vet. So I had a lady the other day and I loved it. She came in and she was saying to me, I really do think that my dog's more uncomfortable in the evening. I just think he doesn't settle well. He seems okay in the morning. What am I seeing? And I was like, well, it sounds like your dog's got a bit of breakthrough pain here. So whatever we're doing, we need to change things around a bit and see if we can get his pain relief to potentially stretch out through the day. And I was like, good on you for saying that. And she was like, oh, I thought I was seeing things. And, so if you see something, write it down, go to your vet, talk about it, because it's more than likely there is something that we can do. Number 5.
I know I'm stealing the big one. Weight. You got
yes.
You can't have a chubby dog, even though they're cute, or a chubby cat. I know we're doing canine arthritis, but I'm gonna plug for the cats too. It's just like in people, it's so much harder by the time we think about it. Like if we just can't let them get overweight. Once we're overweight, it's so hard to lose weight. And
it totally is.
Just age.
We did a fantastic Facebook Live with Helly, and I can't say her surname because it's Dutch, but it means little owl. So there you go. I do know that.
Oh, I like that.
Anyway, did a brilliant Facebook Live with her talking about the biomechanics of obesity, and it's not just the mechanical weight, and it's not just the inflammatory mediators. It actually makes them move differently, and abnormal movement on joints is the worst thing for OA. So yeah, 100%. Number 4, I am the ball police tonight. Think about the activities that you do with your dog. If I had, I've got a painful shoulder at the moment. So if I start flinging the ball again and again, it is going to aggravate it. So if your dog is chasing the ball, twist, twist, twist. Oh, actually, that did hurt.
Don't hurt yourself.
Don't hurt yourself on the camera. No, think about the activities that you're doing. Use your common sense. You might think that they're having a wicked time, but they're high as a kite on neurochemicals. And when those neurochemicals go, they're going to go, I'm really sore. And I don't know why, because I can't associate the ball play, which was 5 hours ago, with how I feel now. They're not going to get it. They're not going to be the clever one. You have to be. So think about changing your activities. Number 3?
Yeah. No, that's such a good one, because I always tell people you have to be smarter than your dog, right? Your dog will throw and get that tennis ball until it literally dies, because that's fun. It doesn't understand that it's not a good activity. They're not the same as people. And so we just have to be, and I don't even know if this is number 3, but I just think we have to, we have to be the advocate, and we have to be smarter than they are, and think about what's good for them. And I do the same thing. I know we're way over time, but I do the same thing with my own dog. It lays around, and then I'll go run it for 3 miles and it's sore. And it's well, of course, what am I doing? Of course it's sore. It doesn't do that. It has to warm up and cool down and stretch and do all the things that we do. So
yeah. And I think that's so important. Right when I started CAM, if anybody was that geeky and they wanted to go right back to the beginning, I did loads of experiments on myself and videoed myself. And I gave myself delayed onset muscle soreness by going to see a PT instructor. Oh my God, it's so painful. It's so painful. And then I tried to ease my DOMS by going swimming. I nearly drowned. It was just not nice at all. But anyway, number 2 from me is spread the word, guys, because I know as a dog owner, if I'd known more about Holly's problem sooner, Holly was my previous dog, I would have had more options, and I would have been able to put lifestyle changes in place that would have had a bigger impact, because I kicked the football, I threw the ball, I did all of the things that I now tell people not to do, because I didn't no.
No.
And I think that having the confidence to talk to family members, friends, and just say, do you know what? Dogs don't express pain how we'd expect them to or like them to. And, looking at dogs' posture, looking at the way that they're walking, looking at their age, looking at their breed. I'm a bit concerned that this laziness, getting old, slowing down, there's an underlying problem. And being able to have a chat with your friends and just say, have you thought it could be something else? And it really would be worth you getting a vet check. Could change that dog's life. It really could. Number one
is just believe, as I do, that arthritis management is going to give your dog the best quality of life, and you are going to have your dog around longer. And if you understand that point, then you will get on board with telling, to your point, your friends. You'll advocate for your dog because it's going to give you more time with your dog.
Yeah. Have you seen our hashtag? I don't know if you'll be able to see it. It's on my hoodie. Can you see it?
Yeah.
Your dog more years. That is our hashtag, because that is, do you know, we're sisters from the other side of the world. This is so true. Yeah, please come over. So it really is. And that was a hashtag right from day one, in that when you incorporate a multimodal approach, you are going to get your dog more years. It's 100% true. So please do embrace these changes, grab them, bring them in. We've got a couple of courses out. So anybody that hasn't done a course, we've got CAM Essentials for owner, 12 little 20-minute modules talking about weight, exercise, how the drugs work, how the supplements work, so you can have a better understanding. There's CAM Comprehensive, which is slightly longer, so you have to listen to me for longer. Each module is about 30 to 40 minutes, and you get all the downloadable booklets. If you're a canine professional, we've got CAM Advocate Level 1, so you can learn about loads of stuff and take it back into your career for career progression. And we now have a course for vet practices, reception, nurses, and vets. We have 3 courses that come together, so you all sing from the same song sheet. So we've got all different areas covered to help you guys do a better job. Amazing. It's just amazing. I'm going to say thank you to our sponsors again, just because we should.
Yes.
Thank you, PulseVet, for bringing this lovely lady into my life. I'm very, very happy to meet the awesome Dr. Jen.
Thank you.
We had a total panic because her hair is really beautiful tonight, and I had to tie mine up. I was like, oh, good. I can't. This is just too difficult.
I know. I do want to answer that gracilis question, though, after we're live.
Yeah, there's a gracilis, and then there's also a laryngeal paralysis. So let's do the gracilis. Go for it.
Because I just want to say that we are actually, it's retrospective, but that's one of the most difficult things to treat. And Dr. Leilani Alvarez, who is a specialist at Animal Medical Center, is using the shockwave on fibrotic myopathy and having some pretty good results. It's not to your point, it's not the magic bullet. It's not going to be the cure, but we have such a hard time improving that at all. And then they end up in surgery with it cut. And so she is going to put together a little retrospective study for us on the fibrotic myopathy, because
that's going to be fascinating.
That is cool. And we were on our small animal advisory board meeting. And so it's all these like amazing vets, right? And surgeons and rehab people. And they were all like, what? We didn't, they didn't know. It kind of blew their mind. So
I think there's already some case studies about it, isn't there? Because we did a little bit of a search, and there has been positive results already released in papers. But I don't think it was a controlled trial. I think it was a review of cases that had
a couple. So we're going to try and nail it down, right? Get a little bit more research, because that would be huge. That's a very, very debilitating and frustrating.
Very debilitating. And then this last one, in my mind, I can't see it being of benefit, because that is a neuropathy. So that is the actual nerve conduction and function that's affected, rather than any kind of structural change.
Correct.
So would you agree?
Correct. I agree with you. At this point, we don't have any evidence that it can affect a nerve like that. If it was a muscular thing or something else, maybe, but to your point, that's nerve damage that stops working. So I wish.
Yeah, we all wish. We're going to become Facebook buddies. I love it. I love getting to meet new people that have this same love for this horrible disease, but something that we can do so much more for. So thank you from the bottom of my heart for coming on and sharing your lovely wisdom and experience. I hope everybody says thank you. These Facebook Lives can take months to coordinate. This one's been in the making for at least 3 to 6 months now.
Yes.
So it's great to have got it in the bag. And I want you back to come and talk more. So hopefully we'll be seeing Dr. Jen again soon. Until then, thank you guys for listening, and we will see you next week.
Bye.
Bye.
Thank you.